started. Anyone need a couple of extra minutes? Everyone okay? All right, hearing no objections, we're going to move forward. So, I am Corey Daniels. I'm the PGY2 oncology resident here at Bethesda University Medical Center. And today we're going to go more in depth on the treatment of breast cancer and work on some cases and try to make it a little more applicable to y'all in like a real world setting. So in the pre-class lecture, we discussed a little bit of the background of breast cancer. So based on the pre-class lecture, did anyone have any questions they wanted to discuss right quick before we dive into the treatment? No? Great. All right, so to go a little more into depth about the treatment, as you learned in the pre-class lecture, breast cancer is classified as different stages. So stage 0 is this carcinoma in situ, so it's very localized. So the primary modality here is surgery. And patients can receive a mastectomy, which is complete removal of the breast tissue, or they can have a lumpectomy, which is breast conserving therapy. These patients can also have radiation if they would like to just further kill any cancer cells that might not have been removed by the surgery, or that these patients could receive endocrine therapy if they had the appropriate biomarkers. We'll go a lot more into endocrine therapy and the biomarkers a little bit later. And then for the early and locally advanced stages, so this is stage 1 and 2 and 3. And the primary modalities here are surgery and radiation with or without chemo. And this chemo can be before surgery, which is termed neoadjuvant to help get the tumor size a little bit lower. Patients have surgery, and then they have adjuvant chemo, or the chemo is after the therapy. And then if the patients are estrogen receptor or progesterone receptor positive, they could also have endocrine therapy for 5 years. And then the treatment for metastatic, this is cancer that has moved beyond the initial site of the breast, so it's in another organ. And for these patients, it's systemic therapy, and that is based on the biomarker status. So we'll go a lot more into all of these a little bit later, but just as an overview, triple-negative breast cancer is treated with chemotherapy. If it's this hormone receptor negative, so the ER negative, PR negative, or HER2, so that's human epidermal growth receptor 2, patients will have anti-HER2 targeted therapy. And then if they are hormone receptor positive and ER2 negative, they'll undergo endocrine therapy. And if they are triple positive, they have a couple of options here. They can have endocrine therapy with or without anti-HER2 therapy, or chemotherapy with anti-HER2 therapy. So now I want to go a little bit more in depth about the treatment of early stage and locally advanced. So again, this is our stage 1, our stage 2, and our stage 3. So this slide says adjuvant therapy, but the concept also pertains to the neoadjuvant setting. So just keep that in mind that this is also pertinent to that setting. And again, like I said, based on biomarker status. And we talked about that in the pre-class lecture. The estrogen, the progesterone, and the HER2 are all receptors that are stained. And if it pops up positive, then that means these receptors are active. So estrogen can stimulate the tumor cells, so progesterone. And if it's triple negative, again, chemotherapy, hormone receptor negative, HER2 positive, that combination. And then as we kind of go more into like the hormone receptor positive, HER2 negative, you have a couple of options that we just discussed along with triple positive. These slides are on ELC for everyone's convenience, if I didn't already mention that. The chemotherapy for HER2 negative, dose-dense AC, so that is adriamycin or doxorubicin and cyclophosphamide, followed by paclitaxel is considered the standard of care. And then TC is another regimen, the T standing for Taxol or docetaxel, and then cyclophosphamide. So the dosing regimen for dose-dense AC followed by paclitaxel. The doxorubicin and cyclophosphamide are given on day 1 of the cycle, so that's given every 2 weeks for 4 cycles, and then paclitaxel is given also every 2 weeks for 4 cycles, or it can be given every week for 12 weeks. The doxorubicin and cyclophosphamide combination is considered highly emetogenic, so that does require 3 or 4 drug prophylaxis. That can include a neurokinin 1 antagonist, a 5-HT3 antagonist, dexamethasone, with or without olanzapine. So you can have 4 drugs, including the olanzapine, or 3 drugs without the olanzapine. Or you can have a 3-drug therapy as olanzapine, 5-HT3 with polynositron, and dexamethasone on day 1, followed by olanzapine on days 2 through 4. And this regimen does carry a risk for delayed nausea vomiting, so that's nausea vomiting after the initial 24 hours. So you would want to give all these patients prophylaxis for a couple of days after the regimen. This is also a regimen that's high risk for febrile neutropenia. And that is based on a risk stratification dependent on disease, chemo regimen, and patient factors, and the treatment intent. I'm not going to go into all the specifics about how it's calculated. I just want you to be aware that there are some things that go into determining whether a patient is high risk or intermediate risk. So for the filgrastim, it is weight-based at 5 mg per kilo, rounded to the 300 or 480 micrograms syringe. And this starts 24 hours after chemotherapy is completed. And then for these patients, it will continue until the ANC recovers. Pegfilgrastim can also be given as a one-time dose of 6 milligrams, and that's also given 24 hours after glucose. I'm going to start talking a little bit more about the drugs specifically, and I want to start with the anthracyclines. So the drugs in this class are daunorubicin, doxorubicin, epirubicin, and idarubicin. And the mechanism of action is they work by inhibiting DNA topoisomerase 2, and that causes intercalation of the DNA base pairs, so it inhibits DNA RNA synthesis. It's also a powerful iron chelator, so the iron and anthracycline complex binds to the DNA and produces oxygen-free radicals that can then cleave the DNA. It is hepatically metabolized, so it does require dose adjustment for liver dysfunction, but it does not require dose adjustment for renal dysfunction because it's primarily excreted through the feces. A major and unique toxicity to this class is cardiotoxicity. And it is chemotherapy, so it can also cause myelosuppression, GI toxicities, alopecia. This is a medication that can be extravagant, so it has to be monitored depending on what line it's going through, whether it's peripheral or central, and then it can cause discoloration of the fluids. Rubicin in the name, so red. The anthracycline-induced cardiotoxicity is due to the free radical oxygen formation that causes myocyte damage. And this is a chronic and cumulative effect. It is dose dependent, and it can lead to a decrease in the left ventricular function. It can cause heart failure. The dose threshold for doxorubicin, the lifetime maximum dose is 550 milligrams per meter squared, but there is an increased risk of this cardiotoxicity starting at 450 milligrams per meter squared. There are different thresholds for other anthracyclines, so if a patient receives idarubicin or epirubicin, you might need to do a little dose equivalent to figure out what is their doxorubicin lifetime max, because that's usually how it is presented. These patients have to have a baseline echo before they start to assess their ejection fraction, and it should be monitored periodically. Other pertinent monitoring includes liver function tests and bilirubin, the baseline echo, and then also how many prior doses received. So with every cycle, you should know, okay, my patient has received X number of milligrams per meter squared of doxorubicin equivalents. Doxorubicin is an FDA-approved agent to prevent those cardiomyopathy, and it works as an iron chelator, so it binds the iron, which is a cofactor needed for this oxygen radicals that we talked about. Excuse me. The dose is a 10-to-1 ratio of dexrazoxane to doxorubicin. So if the doxorubicin is 50, then the dexrazoxane would be 500. It is also approved for the treatment of anthracycline extravasation. However, this dosing is different, so it's important to keep that in mind that depending on the indication, the dexrazoxane dose will be different. And this is 1,000 milligrams per meter squared on days 1 and 2, 500 milligrams per meter squared on day 3. Moving on now to the cyclophosphamide portion of the AC, it also works as an aquating agent, so it prevents cell division by cross-linking the DNA strands and it decreases DNA synthesis. This also requires adjustment for liver dysfunction, and it is a prodrug, so it has to be metabolized by the liver in order for it to become active. Once again, it has minimal renal adjustment, renal excretion, therefore renal dose adjustment isn't really required. A major and unique toxicity with this medication is hemorrhagic cystitis, along with the other vasopressin and GI toxicities. The hemorrhagic cystitis is caused by a cyclophosphamide metabolite called acrolein that just sits in the bladder and it irritates it, and that causes blood in the urine. So it's seen as hematuria, and it can also be frequency and irritation. The patient might complain of any of those symptoms. And for prevention, you want to encourage the patient to have vigorous hydration, to drink a whole lot of water, and Mesna is a medication we can give as a neuroprotectant. It is important to note that not every dose of cyclophosphamide requires Mesna. So really high doses of cyclophosphamide would require Mesna, but low doses would not. So monitoring with this medication, as you would expect, you would want to baseline urinalysis and prior to each dose to assess is the patient developing hematuria. Paclitaxel is the third medication of that dose-dense AC and T regimen, and it works as an anti-microtubule. So this promotes the assembly of microtubules. It stabilizes those microtubules that are already existing, and then it inhibits disassembly. So it prevents cell replication in this way. Once again, hepatic metabolism, so adjust for liver dysfunction, and then no renal adjustment necessary. Pertinent toxicities here are peripheral neuropathy, and this can present to the patients as numbness or tingling. It might be a burning sensation, like their hand fell asleep. It's important to let them know because it can affect their activities of daily living. So if they experience these problems, this is manageable with other kind of medications such as gabapentin. So I always counsel my patients, let me know if you're experiencing this because we can do something about it. Another unique side effect is a hypersensitivity reaction can occur, and that's due to the chromophore in the infusion, and it can cause histamine release and hypertension. So it's not a true IgE reaction, but it can present as one. So you want to pre-medicate the patients with a corticosteroid and then an H1 and H2 blocker. And then monitoring here liver function tests. Moving on to HER2 positive disease. The chemotherapies that are used to treat HER2 positives are similar to the ones that are used to treat HER2 negative, but now you have the addition of an anti-HER2 targeted agent, such as trastuzumab, with or without pertuzumab. They are given along with chemotherapy, and then they can be administered as monotherapy up to 1 year. And they may also be given concurrently with endocrine therapy for the triple positive breast cancer. So you can give the HER2 positive agents with the chemotherapy at the same time concurrently as monotherapy 1 year after, and then in patients who are triple positive, you can continue the HER2 positive therapy and also give them the immunotherapy. Going a little bit more into that endocrine therapy I was talking about, it is used for patients who are, as you would expect, hormone positive. So that's estrogen receptor positive or progesterone receptor positive. And it's following surgery for stage 0 to 3 to reduce the risk of recurrence. It started after chemo and it has continued for at least 5 years. And in some patients, it may be extended up to 10 years. There is a specific definition for menopause, and the definition is a permanent cessation of menses. This can be caused by a couple different reasons. So if the patient has had a prior bilateral oophorectomy, if they are age greater than 60, if they are age less than 60, but they are amenorrheic for at least 12 months, in the absence of chemo, endocrine therapy, and ovarian suppressing agents, or if they are age less than 60 and they're taking endocrine therapy and follicle stimulating therapy and estradiol in the postmenopausal study. So it's really important to determine if these patients are premenopausal or postmenopausal, because that can determine what agents you can use or how you use them. So both premenopausal and postmenopausal women can have tamoxifen. But when it comes to an aromatase inhibitor, premenopausal women have to have ovarian suppression in order to have it. That's very important, that if you are premenopausal, they have to have ovarian suppression in order to also be on an aromatase inhibitor. Going a little bit more in depth into tamoxifen, it works as a non-steroidal estrogen receptor antagonist. So it decreases DNA synthesis and inhibits estrogen effects. So in cells that are promoted to grow by the presence of estrogen, the tamoxifen prevents this growth. The dose given is 20 milligrams daily, and no renal or hepatic doses are required. Pertinent and important toxicity here is thromboembolic disorders, so you would need to counsel your patients. They're at increased risk for DVT or PE to monitor for the signs and symptoms of that. It works as an anti-estrogen, so patients might experience menopausal symptoms, so you want to counsel them about hot flashes, arthralgias, and potential mood changes. And then bone mineral density is a toxicity depending on if you're premenopausal or postmenopausal. It's actually protective in postmenopausal because it acts like an estrogen on the bone in these postmenopausal women. However, in premenopausal women, tamoxifen is an adverse effect, so it decreases the bone mineral density because it acts as an estrogen antagonist on those patients. So the premenopausal patients would need calcium and vitamin D supplementation. As for the aromatase inhibitors, they work by inhibiting the enzyme that produces estrogen. And again, you only get these in postmenopausal women because they are not as effective in inhibiting ovarian estrogen production. So that's why in premenopausal women, you would suppress the ovaries. It's better at inhibiting aromatase in other areas of the body, such as in the fat and the muscles. And then ovarian aromatase dramatically decreases after menopause. Anastrozole, letrozole, and exemestane are the 3 drugs in this class, and they're all given daily. There are no dose adjustments required for the exemestane or the anastrozole, and letrozole should be adjusted for severe hepatic dysfunction. Toxicities are similar to tamoxifen because they both work in reducing estrogen. So decreased bone mineral density is seen, so you want to evaluate these patients at baseline and also provide them with calcium D supplementation. And it can cause hypercholesterolemia, so you want to check a lipid panel at baseline and then periodically. We're going to start with our first case. I believe y'all should have a copy of these. So patient MB is a 43-year-old black female referred to the cancer center after finding suspicious mass on the mammogram. she had a corneal biopsy, and that showed stage 2B breast cancer. Genetic testing revealed that she is BRCA1 mutation positive. So her pregnant past medical history, type 2 diabetes, and fibrocytic breast disease. Social history, she denies smoking, alcohol use, and illicit drug use. She's not married and she has no children. Familial history, she had an aunt that was diagnosed at age 37 with breast cancer, and then some pertinent other information about her is she had her age at first conceived was 11. So group 1, tell me what are in these risk factors for developing breast cancer?
She has a BRCA1 mutation and a O.
Yes, so certainly BRCA1 mutation is part of it. She had a couple of other ones. Think about her family history, think about some of her own personal history.
Her age of first menses was early at age 11.
Absolutely. Can you tell me what is the definition of early menarche? What is that age?
Isn't it any time before 12?
Yes, that's correct. So great job on that. So yeah, she had early menarche, she had the BRCA1 mutation. I'm looking for 3 more things.
She has an aunt that was diagnosed with breast cancer, and she has fibrocytic breast disease.
Absolutely. So what age does the family history come in? Like what age of the family history are you at more increased risk?
Before 50 years.
Yes, absolutely. And there's one more thing about her her personal history that also increases her risk.
She never had children.
Absolutely. Great job, group 1. So based on these risk factors, group 16, tell me, what are prophylactic measures that can be considered for her?
Bilateral mastectomy, or a bilateral oophorectomy.
Absolutely, yes. And that is a little controversial about what patients should do to reduce their risk. So absolutely, it is a patient and physician specific discussion for each one, but that is something that she can talk about and undergo. So what is the goal for treating her disease? Remember, she's stage 2B, and what are her treatment components? So group 8, what's her goal, and what are her treatment components?
The goal is cure, and we could do surgery, radiation, and chemo.
That is absolutely right. So remember, stage 0, 1, 2, and 3, these patients are curable, and then they can have this multimodality. Great job. All right, the oncology team decides to treat MB with adjuvant Dostin AC followed by paclitaxel after her surgery. So she did undergo the bilateral mastectomy and the SPO to reduce her risk. So at this point, group 2, tell me, should any other workup or labs be performed before she starts her therapy? So she's on the doxorubicin, cyclophosphamide, and paclitaxel.
They should get a liver function test with bilirubin and baseline echo.
That is all correct. There's one more thing that she needs to be tested for with her cyclophosphamide. Is your hint?
The baseline urinalysis to detect blood and urine.
Great job. Did you say the molecular biomarkers?
No, I don't think so.
No? Okay. So yes, for these patients, every single patient should undergo molecular biomarkers to determine what kind of treatment they can get. Because if they're triple negative, that treatment is extremely different than if they are triple positive. And with breast cancer being so biomarker driven, every patient should undergo this. All right, so group 7. What modifications would you make if she was ER and PR negative and HER2 positive?
The next group, she's ER positive.
No, she's ER, PR negative and HER2 positive. So hormone receptor negative, HER2 positive. What would y'all do?
Oh, sorry, trastuzumab.
Absolutely, or pertuzumab. So you can add that one of those anti-HER2 therapy options. There are other ones, but these are just the ones we're going to focus on for the purpose of y'all's learning. And then if the patient is ER/PR positive, so this time she is hormone receptor positive and HER2 negative.
My enrollment's in group 7.
I'm sorry, what was that? What, oh, you know, I actually forgot what group I had called on, so we're just going to go with group 4. Sorry. Group 4. What would you do if the patient is hormone receptor positive and HER2 negative?
We could add endocrine therapy.
Yes, you can add endocrine therapy after the chemotherapy has completed. And then also to that group, what would you do if they were triple positive?
Give the chemotherapy and anti-HER2 therapy together and then follow that with endocrine therapy.
Y'all are killing it. Great job. All right, we are continuing on with NB. So what is the Augusta group number for y'all? Great. Okay, group 20 here in Augusta. What supportive care issues should be addressed with this dose-dense AC?
The high metagenicity
And
and febrile neutropenia.
great job. So we're going to go a little bit more into this. I believe y'all should have already had a CINV lecture, and this is just extremely important because this is one of the most important things we as pharmacists can do to help these patients is optimize their pharmacotherapy treatment here. So CINV prophylaxis, what are our options? How many drugs can we give them for this high risk?
3 or 4.
Exactly, 3 or 4. And then, so if you give 4 drugs, what are our drug classes?
NK1 antagonist, 5-HT3 antagonist, dexamethasone, and amlodipine.
Great. And then we have 2 different triple drug therapy options. What do those include?
The dexamethasone or the olanzapine.
Along with the polonosetron. Very good, very good. Getting all these are by mistake. Oh, no. Okay, well, we're gonna change the math then. So, same group, each cycle of doses AC is 60 milligrams per meter squared of doxorubicin and 600 milligrams per meter squared of cyclophosphamide. What would her lifetime maximum be after 2 cycles? So I already gave you the answer if she had completed the full course of her treatment. So if each cycle contains doxorubicin 60 milligrams per meter squared, what has she received after 2 cycles? Simple math. Yes, exactly, 120. So again, every cycle you want to keep up with how much is she getting, because these patients are at risk of relapse. So this patient at the end of 4 cycles gets 240. Well, that's important to know is 5 years later, she has to get the 200 again.
Lifetime. Did she say how many cycles? Like it's
As you're remembering, are there questions?
Is it 3 or 4?
It is 4. I just messed up, so for the purpose of learning, I just changed it.
Okay.
Yes, but it is 4 cycles, so at the end of her 4 cycles, her lifetime dose would be 240. So, knowing that each cycle completion, or I'm sorry, at the end of each treatment regimen, it will be 240. How many cycles can she get before she reaches her life, or I'm sorry, how many treatments can she get before she reaches her lifetime maximum?
2.
Very good.
I might have to say that in the microphone.
Oh, sorry. Yes, so Augusta accurately said that this patient can have basically 2 4-cycle treatments with doxorubicin in order to get her under her lifetime maximum. So group 17, I like forcing participation. Group 17, what counseling points would you discuss with ND? Overall. So what are just the very general counseling points you would say about chemotherapy?
Peripheral neuropathy, hyperpaclitaxel specifically.
No, I think she said overall. Overall counseling.
Overall, right. Yeah, because we're going to go into the drug-specific ones.
Well, I would warn her about nausea and vomiting because she's getting a highly immunogenic chemotherapy regimen, and then explain to her what drugs she's going to take on what days, and to take them as soon as she starts to feel nauseous, and not to wait until after she's like throwing up.
Great. So we have one very appropriate and very well counseled of the toxicity. So GI toxicity, absolutely you want to counsel on how you're going to take your medic regimen and have options available to them because you want to prevent this treatment. So, or you want to prevent this toxicity. There are 2 more.
Watch out for fever, since she's at a high risk for febrile neutropenia.
Absolutely. Yes. And then there's a 3rd one that they all cause.
I'm sorry, we couldn't hear that. Can they use their mics?
I am so sorry. I forgot they weren't using their mics. So they said fever because these patients are at high risk for febrile neutropenia. So we want to counsel them on what is a fever, what to do if you have a fever. So the answer is you go to the hospital. And all of these patients, if they have a fever, they go to the hospital because they might not have an infection, but if they do, then they have to be worked up and have to be treated appropriately. So there's one more that's more of a cosmetic issue.
Don't wear like light clothing because they're going to sweat red stuff with the doxorubicin.
Mike.
No.
No, not that one. So it was, don't wear light clothing because they're going to be sweating. That wasn't really what I was looking for.
Oh, is it alopecia?
Alopecia was correctly identified. So the overall major toxicities that you can pretty much counsel any patient on for any chemotherapy is GI toxicity, so nausea, vomiting, mucositis, myelosuppression, and alopecia. So the way I counsel my patients, I tell them chemotherapy kills rapidly dividing cells. which is great because that's your cancer, but that also includes some of your normal fast-growing cells, which are your hair, your GI tract, and your bone marrow. So it kind of puts it in perspective as to why am I experiencing these side effects. And then for, okay, so same group, doxorubicin. What specific things would you counsel there?
The cardiotoxicity.
And what specifically would you tell them about the cardiotoxicity? So what signs and symptoms would you tell them to look for?
Shortness of breath and easily fatigued.
Absolutely, along with edema, right? And then there's another one, so what specific to doxorubicin would you want to counsel them on?
The discoloration of body fluids.
Absolutely, it is red. And I've actually had the situation where a patient got their doxorubicin before I could go talk to them. I warned them, oh hey, this is a side effect, it's fine. And they were like very concerned about it. So definitely let them know before they experience this that, hey, you're gonna get this, but this is normal. Because you know it's gonna freak them out. All right, same group, 2 more drugs. Cyclophosphamide, what are you going to counsel them on?
Like you might see blood in the urine or urinary frequency and irritation.
Absolutely. So we're going to tell them to do about it. How are you going to tell them to like help? What can they do to help prevent all that?
Stay really hydrated.
Absolutely. Stay really hydrated. And it's a little difficult with this drug combination, the doxorubicin with the cyclophosphamide, because typically you just tell patients, oh, look for blood in your urine. But their urine's already supposed to be red. So that doesn't really help them. So that's why we have to do the urinalysis before every cycle just to make sure this isn't occurring. And then lastly, paclitaxel. What are the 2 side effects that are unique there?
The peripheral neuropathy, and we can give the patient gabapentin for that, and then the hypersensitivity reactions we can pre-medicate with the steroids.
Fantastic. Okay, so we're about to go into case 2, but I want to give anyone opportunities to ask questions. I know that was a lot of information all at once.
How do you know how many cycles, will the doctor tell you how many cycles?
Yeah, so they'll give 4 cycles.
Okay.
So that's just standard. And then if they need some more cycles in the future, that's going to be dependent on if they relapse, how did they respond the first time. There are a lot of different things. If their performance status even allows for them to get intense chemo. But just for the purposes, for y'all's knowledge, dose-dense AC is 4 cycles. Great question. Any other questions before we move on?
How do you calculate that maximum? Like the
Yeah, so
240,
the question
how did you
was,
get
how do you calculate the maximum dose? So it's 60 milligrams per meter squared. So you don't actually calculate, okay, this is the patient's body weight, and then, from there, what is it going to be done? You just take the, 60 milligrams per meter squared. How many cycles are they going to get? So you multiply it by some number, and then that number has to be less than 550. Does that make sense?
Mm-hmm.
Any other questions? Great. All right, I've picked on and passed on that for now. Let's see, group 9. Group 9. Patient EP is a 52-year-old female with hormone receptor positive, HER2 negative, ductal carcinoma in situ, who is referred to the cancer center after undergoing breast-concerning surgery, and the oncology team wants to give adjuvant endocrine therapy. So what do you need to know before deciding what adjuvant therapy you're going to give her?
Whether she's pre or postmenopausal.
Absolutely, because again, that's just very important to know because you are limited or you have to finagle some things if you want to give them the aromatase inhibitors. So what is the treatment goal for her disease?
Prevention of disease, progression, and cure.
Great job. All right, so same group, those were softballs. So what therapy option would you choose if the patient is premenopausal? And postmenopausal, we can do that all at once.
So ovarian suppression and aromatase inhibitor for pre, and just aromatase inhibitor for post.
Absolutely. And there's another drug class or there's another drug that can be given to either.
Tamoxifen.
Great job. And remember, all of these are just daily, and then the dose is what it is. So what counseling points would you discuss with EP? Same group.
Tamoxifen can cause thromboembolic disorders, and she may have some menopausal symptoms like hot flashes, arthralgias, and mood changes.
Absolutely. And there's one more pertinent one.
Some metabolic changes.
Yeah, so the bone mineral density changes, absolutely. So what would you, if she's premenopausal, what would you counsel her to take?
Calcium, vitamin D.
Excellent job. And let's talk a little bit more about the thromboembolic risk. What kind of specific signs and symptoms would you tell your patient to look for? Because these patients are going to be at home, so they need to be educated on what do they need to be monitoring on themselves.
So just signs of thromboembolism like shortness of breath, dyspnea, things like that.
Absolutely, yeah, and swelling and redness and pain. If it's like a DVT. Great job, all great. So we're going to switch gears. Yes, I have a question in Augusta.
Did they ever give like aspirin or anything for that risk, like prophylactically?
They don't, and usually that's because these patients have myelosuppression, so either their platelets might be less than 50, and it's not a primary cardiac kind of thing, so it's more just a we watch. Great question. We're going to move on to the treatment of metastatic breast cancer. Before we do, any other questions? That was a good question. No? Great. So starting off, triple negative breast cancer, there are a variety of chemo regimens, and there's no standard of care. It's pretty much just pick your poison. And single agent therapy is preferred because the goal of this is not cure, it's just palliation. So you don't want to just destroy their lives with all this chemo. So you can give them an anthracycline, a taxane, capecitabine, gemcitabine, or some new drugs, vinorelbine, eribulin, or microtubule inhibitors. And then if the patient is BRCA1 or 2 mutation positive, you can give them a PARP. They are a category 1 recommendation for the NCCN if the patient is BRCA mutation positive. But you would not want to give these to this patient if they are BRCA mutation negative. That's important. And then, as I mentioned, sequential therapy is preferred, but combinations of chemo if the patient has a high tumor burden, if it's rapidly progressing, or if it's a visceral crisis. A little bit more about the PARP inhibitors because this is a relatively new class. So the mechanism, it works by poly-ADP ribose polymerase enzyme inhibitor. So what that means is it prevents repairs in double-stranded DNA breaks, so it just compounds DNA damage. The two that are approved for breast cancer are olaparib and talazoparib. There are a couple of other ones that are approved for ovarian cancer, so remember that these are the two for breast cancer. The dosing for the olaparib, 300 twice a day without regards to food. Talazoparib, 1 milligram daily without regards to food. They both require renal dose adjustment, and the typical toxicities, myelosuppression, GI, and then also fatigue is common between the two agents. And then mouth sores, infection, and skin rash are unique to olaparib. And then increased blood glucose, increased LFTs, and alopecia are more unique to the talazoparib. And then monitoring BRCA1 mutation status, we have to know that before we start. Also CBC and renal function. In patients who are estrogen receptor positive and or progesterone receptor positive and HER2 negative, they're premenopausal, again, tamoxifen, we can get into the ovarian suppression with endocrine therapy. This endocrine therapy does include aromatase inhibitors and also a couple of other agents. And then that can be given with or without the cyclin-dependent kinase, or CDK, 4 and 6 inhibitors. The patients postmenopausal, they also have a whole lot of treatment options, but category 1 recommendations are fulvestrant, and then CKD 4 and 6 inhibitors with endocrine therapy. And then if they are in visceral crisis, that's when you can consider initial chemotherapy at the front. Again, if you go to NCCN, there are a ton of regimens, and they can be used in such situations and all that. But this is just kind of first line recommendation, some of the drug classes. Fulvestrant is a estrogen receptor antagonist, so it has similar adverse drug events to tamoxifen. And it's administered IM, 500 milligrams every 2 weeks for 2 doses, and then monthly after that. There is an adjustment required for hepatic dysfunction, so you want to monitor LFTs and bilirubin at baseline. And then for the CDK4/6 inhibitors, that includes aromatase inhibitor or fulvestrant in combination with palbociclib, ribociclib, or abemaciclib. Going a little bit more in depth with the CDK4 and 6 inhibitors, they work by cell cycle arrest. So they block phosphorylation of one of the proteins responsible for progression through the cell cycle. There is also a link between estrogen receptor signaling pathway and the CDK4. The dosing gets a little complicated with these agents because they're not all the same. So abemaciclib is 150 twice daily without regards to food. Palbociclib is 125 milligrams daily, 3 weeks on, 1 week off, without regards to food. So, the patients come into the hospital, it's important to know where are you in your cycle. And then ribociclib, 600 milligrams daily for, again, 3 weeks on, 1 week off, without regards to food. General toxicities between the 3 of them: myelosuppression, fatigue, alopecia. Abemaciclib can cause diarrhea, hepatotoxicity, and thromboembolism. Palbociclib can cause other GI toxicities and infection. And then ribociclib can cause hepatotoxicity and QT prolongation. So for all 3 of the agents, you would want to monitor CBC. And then for abemaciclib and ribociclib, LFTs and bilirubin. And for ribociclib, an EKG. These are substrates for CYP3A4. So there are drug interactions, so just be mindful of that with inhibitors. And you also must dose adjust for hepatic dysfunction. All right, moving on to case 3, I'm just going to pick on the campuses. So Savannah, patient EP returns to clinic 4 years after being lost to follow-up with complaints of trouble breathing and a recent seizure lasting about 30 seconds. So a PET scan is performed and shows metastatic disease. Based on your symptoms, what are the most likely sites that the breast cancer has metastasized to?
We're thinking the brain and the lungs.
You are thinking correct. And what other organs are sites that breast cancer can commonly metastasize to? So you have two of them. What are a couple of other ones? So this is based on that pre-class lecture.
Lymph nodes, skin, bone, and liver.
Great job. And as with all of our patients, what do you need to know before you decide to start chemo? Or before you decide to start therapy, I'm sorry.
Any of the biomarkers, and if it's pre or post menopausal?
Absolutely. So postmenopausal status, because this is our patient from case 2, so we do already know her biomarker status, but absolutely for all patients, those are two of the most important things we need to be thinking. What are their biomarkers? What is the menopause status? All right. So Athens, given EP is postmenopausal, what is the appropriate? Oh gosh, I'm sorry. It's already there. Okay, first line option, right. So I'm sure y'all would have come up with these treatment regimens. She was postmenopausal. And then what is the goal for her disease now, Athens?
Her goal is palliative right now.
Yes, it is. Palliative. Very good. All right, Athens. What monitoring parameters should be performed if she is on abemaciclib with fulvestrant or an aromatase inhibitor?
So for the abemaciclib, we would want to monitor CBC, LFTs, and bilirubin. And then also for her aromatase inhibitor, we would want to take a look at a baseline lipid panel.
That is all correct except one thing. Everyone keeps forgetting this one monitoring parameter.
Bone mineral density.
Excellent job. All right, someone else in Athens, what would you do? Same thing for palbociclib, fulvestrant, or aromatase inhibitor.
Would you look at the CBC, LFT, bilirubin, bone mineral density, and lipid panel?
Well, my slides little things are out of order. Oh gosh. Yes, sorry. Sorry, things got out of order. So what? That is correct. You are correct. What counseling points would you want to discuss with EP for the CKD inhibitors? Just all of them in general.
They all cause myelosuppression, fatigue, and alopecia, and then they each have their own individual toxicities as well.
Absolutely. Also, because they are CYP3A4 substrates, you would want to be very mindful of drug interactions. Sorry. So, abemaciclib, you mentioned a great segue into each one has their own toxicities. Someone else, let's say in Savannah, what is a specific toxicity to abemaciclib?
Diarrhea, hepatotoxicity, and thrombolysis.
Great job. All right, someone here in Augusta, what about palbociclib?
GI toxicity, nausea, vomiting, diarrhea, and infection.
Very good. Is there anything else you would want to counsel about, like how to take the medication?
With food.
With food, yes. And what's also a nuance about palbociclib?
3 weeks on, 1 week off.
Yes, they correctly said 3 weeks on, 1 week off. So this was all complicated. You would definitely want to counsel them on take with food and then the dosing cycle. And then what about here in Augusta, ribociclib?
Hepatotoxicity, QTC formulation, and then also the dosing cycle.
Excellent job. Excellent. So Athens, what would you counsel her on for fulvestrant?
Thromboembolic disorders and menopausal symptoms such as hot flashes, arthralgia, and mood shakings.
Very good. And
Bone mineral density.
great job. I'm going to have everyone thinking bone mineral density by the end of the day. And last but not least on the counseling point, Savannah, aromatase inhibitors.
Decreased bone mineral density and hypercholesterolemia.
Wonderful. And if she wasn't menopausal, she might have some menopausal symptoms. She's undergoing ovarian ablation. All right, now we're going back up to monitoring parameters. So we're going to go back to the groups now, take on some of y'all. So group 3. What are monitoring parameters with palbociclib, fulvestrant, or aromatase inhibitor?
CBC, LFT, bilirubin, bone mineral density, and lipid panel.
Excellent job. All right, group 11. Same question for the ribociclib.
CBC, LFT, bilirubin, and EKG.
And everyone here in Augusta said bone mineral density.
Bone mineral density.
Absolutely, great job, yes. And again, EKG is really important because of the risk of QTC prolongation. And then group 10, fulvestrant. Oh, yeah, monitoring fulvestrant.
LFTs and bilirubin.
Very good. All right, we're gonna put case 3 aside. That's, was a little in depth, but everyone did a great job, so thank you for that. Now I want to talk about hormone receptor negative, HER2 positive disease. So So for the metastatic setting, because that's where we are, the metastatic setting, pertuzumab, trastuzumab, and docetaxel is the preferred regimen. Paclitaxel may be used instead of doci, that's fine. It is a taxane derivative similar to paclitaxel, so it works similarly. And the toxicities are also similar to paclitaxel, with the unique one being fluid retention. So you want to pre-medicate the patient with corticosteroids for 3 days. So we counsel the patient take the day before chemo, take the day of chemo, and then the day after chemo. And it also helps with hypersensitivity reactions. And then pertinent monitoring here is bilirubin. About that fluid retention though, it can be severe, so it can manifest as pleural effusions, ascites, and abdominal distension, peripheral edema, dyspnea, weight gain. So not insignificant and something you definitely want to let your patients be aware of. Going a little bit more in detail about this HER2 therapy, we talked about it in the adjuvant setting. Now I want to go more in depth here. So for the pertuzumab and the trastuzumab, they are anti-HER2 monoclonal antibodies, and they bind at different sites of the HER2 receptor. So when they're used together, they actually increase inhibition of the HER2. So it's synergistic. Toxicities here, infusion-related reactions, similarly to all monoclonal antibodies. Cardiotoxicity can occur. It's highest when used in combination with anthracyclines. So you would once again want to monitor an echo at baseline, get that ejection fraction, and then periodically. And this may be reversible. So if it is reversible, that's seen 1 to 3 months after discontinuation. Pulmonary toxicity is unique to trastuzumab, and that can include dyspnea, hypoxia, interstitial pneumonitis, pleural effusions, and acute respiratory distress syndrome in very severe cases. And then diarrhea is unique to pertuzumab. For the treatment of triple-positive metastatic breast cancer, it's really dependent on, you guessed it, menopausal status, but also at what point did they receive endocrine therapy. So if we're premenopausal and she received endocrine therapy within the last year, you can do ovarian suppression and then therapy used for postmenopausal women. Or you can switch gears and go to a chemotherapy with a HER2 agent. If the premenopausal woman has not received endocrine therapy in the last year, once again we can do ovarian suppression with our postmenopausal treatment options, chemo with anti-HER2 therapy, or we can use a selective ER modulator such as tamoxifen with or without trastuzumab. If the woman is postmenopausal, endocrine therapy within 1 year, you would switch to a different line of endocrine therapy with or without this HER2 target. If there have been, or you can do chemotherapy with anti-HER2 therapy. And if there has been no endocrine therapy within the last year, you can do aromatase inhibitor, selective ER modulator, selective ER downregulator, or chemotherapy, and all of these can be with HER2 positive therapy. All right, case 4. So, group 18. ND presents to her oncologist for surveillance following chemotherapy treatment for stage 3A breast cancer 3 years ago. A PET scan is performed and shows recurrent breast cancer with metastases to her bone, and her biopsy confirms she is stage 4, ER negative, PR negative, HER2 positive breast cancer. What is the goal for her disease? Do group 18.
So she is stage 4, it's just palliative at this point?
Absolutely, it is unfortunately palliative. So I will put on group 18 when they get back. Group 15. What is an appropriate first-line option for ND based on her molecular markers?
pertuzumab, trastuzumab, and docetaxel.
Excellent job. So same group. Should any workup or labs be performed before initiating therapy?
You know, that's a great question. We're on the search for this answer.
I appreciate the honesty. That's fine. Take your time. Okay, what time do you normally finish this class?
11.
Do they always go to 11?
No.
So if we are about to end, it's fine.
That's perfect.
I'm very concerned about us not lasting so long. It's usually they don't all last until 11. I'm getting so.
It's preferred.
Preferred not to be, I'm sure. I'm doing a great job with their forced participation.
LFTs and bilirubin.
Yes, LFTs and bilirubin, that is correct. What about anything for the anti-HER2 therapy?
We're going to monitor the LVEF at baseline and periodically.
Excellent. And does anyone know what the pathophysiology is of the HER2 therapy-induced cardiotoxicity? That's fine. I figured y'all wouldn't know. I just wondering if anyone was aware. So it's actually, there are HER2 receptors on the heart. So by inhibiting those receptors, you obviously would be damaging the heart, and that's why it's reversible in a lot of the cases, because you remove the inhibitor and everything's fine. You won't have to know that for the test, but that's just a little fun fact for y'all. Let's see, group 19, I don't think I've done that one. Group 19, what counseling points would you discuss with ND?
Fluid retention and diarrhea.
So y'all heard of it, yes, fluid retention, absolutely. Diarrhea, yes, what are some other ones? Helpful hint, just, when you're just thinking about things, we're able to monitor for something, I might need to counsel my patient on it.
Pulmonary toxicity?
Yeah, absolutely, pulmonary toxicity. Keep going.
Cardiotoxicity?
Absolutely. A couple more things. So, yes, you got those toxicities. A couple more things. One specific to the docetaxel, I'll give you a hint there, and then another one is specific to more of the monoclonal antibodies.
Infusion-related reactions.
Yes, infusion-related reactions. Very good. Someone here in Augusta said that. And then last one. No, so this one was a little tricky because I didn't explicitly say it, but it's actually peripheral neuropathy because it is a taxane, so it does have similar side effects to paclitaxel. So peripheral neuropathy is also pertinent And just for y'all's own fun fact, if it has a the peripheral neuropathy is due to the mechanism of action in the microtubule, inhibition. So for the fluid retention, we're going to give them corticosteroids pre-medication. How are you going to counsel the patient to take those corticosteroids?
Day prior, day of, and day after.
Yes, someone here in Augusta said day before, day of chemo, and the day after chemo. And then for the cardiotoxicity, what specific signs and symptoms are you going to have them monitor for? So the cardiotoxicity manifests similar as doxorubicin toxicity, right? So what would y'all counsel there?
Edema, shortness of breath, all that stuff.
Yes. So Augusta correctly said edema, shortness of breath, again, just congestive heart failure signs and symptoms. So that is the end of the lecture, but I really encourage everyone to please ask your questions now, what you have. Obviously, I can't speak specifically to the task, but if something is unclear, if y'all want some more focus, now is your time to ask.
Well, we didn't know all the specific dosing from these medications, like the cycles and how many cycles and how frequently they're given and everything.
No. You will not have to accurately pick a regimen and know this is everything that is correct about that regimen.
Is there anything in particular we should focus on in studying for the exam?
The things that were highlighted in the cases. All right, seeing no other questions, I'm not going to make everyone just sit there and stare at each other. So, if anything pops up, you can email Dr. Clemens and she can forward the email to me. I don't know if y'all have my email, if y'all need it. But good luck and thank you so much for your participation. Y'all actually really gave a lot of great participation. I really appreciate it. Thank you.